and neurodegeneration. They are a potent painkiller with an excellent patient adherence, and I think they are a valuable adjunct to cancer treatment. About the side effects, there are basically none, with one exception. The procaine, the procluster, or the relief can bring up the heartbeat a little bit, and in about 1 of 1,000 patients, this can be a problem, that you have a tachycardia, and then you just have to stop the infusion. And normally I give 250 mL of sodium chloride, and that's fine. But if a patient complains and you monitor, beat goes up to 120, then just stop it. That's all. I've never seen any problem. I just want to cut it down, and now I think a second thing which you might consider for the future is the cell treatment we do. We don't use stem cells. They have a lot of risks in terms of carcinogenicity and so on. What I do, I take monocytes, white blood cells, I reprogram them to have anti-inflammatory and regulatory properties. This takes 4 days, and then I re-inject them to the patient. And how efficient these are, we have tested first in an animal experiment where we ligated the femoral artery, and then injected either these regenerative macrophages or control cells. And we looked for the oxygen saturation, and in these ligated hind limbs. And this is something which is of interest, and I took out from all the experiments when I did, because for you as cardiologists especially, it will indicate how you can improve the circulation in coronary arteries. In Germany, we spent 3.2 billion euros alone for patients with peripheral arterial occlusive disease. This is a huge thing. And you see in these experiments, animals were ligated. We had a normal right hind limb with the normal perfusion in comparison to the ligated left limb. And we had the animal treated and just treated with normal monocytes. And you see, after injection, this was done intra-arterial, you see after about 4 weeks a normalization of the peripheral oxygen saturation in comparison to the healthy right limb. Whereas if you just take normal monocytes, you see a huge discrepancy in oxygen saturation. So the cells really improved the oxygen supply to the critical hypoxic tissue. And then we went on to patients. My first case was a patient, 67 years old. He was referred to my surgical department for amputation of the left lower limb. This poor guy already had undergone right lower limb amputation, and he suffered from arterial ulceration. And he had been hospitalized for already 200 days. He was septic, and it was really very difficult with any conservative means. But he refused amputation. He said, "I'd rather die than having a second leg amputated." So I got ethical approval from the university to do a healing attempt. And what happened, and here you can read about these reprogrammable anti-inflammatory cells, which we have published. What happened, we took the monocytes from his blood, he tried to reprogram them into deactivated anti-inflammatory cells, but it was impossible. He had such a high level of IL-6 and TNF in his blood, we couldn't reprogram them. But we have demonstrated that these cells can be taken from an allogeneic third-party donor. They are not rejected. So we were allowed to use a healthy student's blood, which was ABO compatible. Actually, you don't have to look for ABO, but the ethical committee told us to do so. But it was different in HLA molecules, antigens. So we came up with 8 × 10⁸ cells from this healthy donor. And you see here, I inject these cells after I did substantial debridement of the ulcers. Everything was plaque and necrotic down to the fascia of the muscles. So I inject 32 injections of these cells around the ulcer. This is 2 weeks later. You don't see very much after 2 weeks, but clinically, the patient reported not to have ischemic pain anymore. And the re-angiogram demonstrated a better perfusion. And what the follow-up of this course, you see after 8 weeks, after 13 weeks, you already have a closure of the skin of the top third of the wound. And this is after 24 weeks. It takes quite a while, but it takes time that the cells initiate a bypass with very small capillary networks. You can see that they form capillary networks around the stenosis. And this is also what happens in coronary patients. And after 1 year, it was completely closed. He lived for 3 further years without ischemic pain in the leg, normal walking distance. But then he suffered from a heart attack and died. But he never had any further problems with his leg. Another example of a diabetic ulcer, you see here, patient was hospitalized for months, and then he got treated, and you see it took about 9 months, and you have a very good epithelialization of the wound. Same story here. After 3 weeks, no more pain in the lower leg, no other treatment. And this was a guy coming with the indication for front foot amputation. You see peripheral occlusive disease, no inflammation, edema of the foot, and a necrotic toe. And I said, well, maybe we certainly will not be able to rescue the toe, but perhaps we were able to do a minor amputation. So he got the cells, and 3 weeks later, look at the tissue. The inflammation is gone. You have a normal trophic skin, and just the necrotic toe was amputated, and he was fine. So this illustrates how the infusion in combination with the cell therapy can really be a very beneficial thing. Now, coming to this is my last point. How could we set up a lab here? I'm now intrigued by a new innovative machine. It's a bioreactor. You see it here. It has the size of this chair, where you just take 100 ml of the patient's blood. You put it in a bag, and you can, in a sterile way, combine it with the machine. The machine sucks in the blood, and it has a centrifuge, which will centrifuge the white blood interface. And then the white blood cells, the monocytes, will be sorted by magnetic beads. After this step, you have a pure product of 98% pure monocytes. And then you put in the media and the growth factors which I use to program the cells. And after 7 days or 5 days, whatever cell you produce, then you come up with an automized product which you can put to a fax machine to look for the specification of markers which we have identified, which are important, and give it to the patient. So this is an integrated cell processing device. It's called Clinimax Prodigy, which actually can handle all current technical requirements for manufacturing cellular products by automation of the complete process in a functionally closed environment. This is important. You don't need a GMP setup with all hands-on and the staff, which costs a lot of money. So this is available, and the advantages are the installment is full automated. You have a central production platform, no investment for the GMP, less personal training, and protection of your know-how. So this is something we could install here, I think, in the next year, if there's interest. I think I want to thank you for your attention, and I'm at the end. Thank you. Yeah. I'm happy to take your questions.
The lab test which you were mentioning, all the
Yeah,
have you done any other lab or
well, as I told you, what we do in comparison in addition is high sensitive CRP and homocysteine levels.
What about all the other things?
Well, you have basically 4 different colors there, and green is for glycoproteins. They precipitate in the electric field in an acid pH range. Then the lipoproteins, which are normal pH range, and the immune globulins, that's the blue dots, which indicate activation of the immune system. And the purple dots are broad scope proteins. They indicate sclerosis, aging, and so on.
So can you qualify at any lab?
Yes. Well, no, not any lab. That's the problem, sir. We have to send it to a specific European certified lab in Brussels. And I also have the problem, it takes me 2 weeks to get the result. But nevertheless, if you do patients, if you have patients where you know they come every 3-4 months, then you can really monitor them over the year and see how your therapy is working on them. It's not for acute diagnostic, but for ongoing monitoring, it's very nice. And if you want, I can give you or I can, next time I come, by end of the year, I will bring sets. So I will inform you, if you want to do that for your patient, the costs are 120 euros for one test. Then you can send it to Brussels. I will speak to my colleagues in Brussels, and because they do it from Singapore as well. Okay. I don't think it's a problem. And I will teach you, it takes a little bit experience in the beginning, how to interpret the shift of these dots. Okay?
Thanks, Prof, for your talk. It's a really eye-opener. Regarding the last few cases that Prof shared with us, it's amazing to see how the wound healed after the administration of the monocytes. Do you do it intralesional or intravascular?
Well, I only do it intramuscular, like in this case, if you have a real open ulcer. Normally, if you have patients with ischemic disease, either stroke, or if you see the carotid artery, or in the extremities, I do it intravenously. Because they have chemokine receptors which locate them to the spot where the inflammation is going on.
So apart from the clinical appearance that shows improvement, is there any more concrete parameters like the perfusion of the
yes, of course.
That shows that improvement after?
We measured the peripheral oxygen saturation, which was going up as in the animals, and we also did thermography, which showing that the leg is warmer. Yeah.
What about heart failure?
Huh?
Heart failure?
Heart failure is a very good indication. I started for ethical reasons with patients who had 3-4 bypasses, stented. So the cardiologist came and say, well, this is your patient now. I can't do anything anymore. He's too old for a heart transplant. And it is like a little miracle. Within 3 weeks, he will not report any angina anymore. And for instance, my colleague in Germany, who's 67 years old, he had coronary heart disease with an attack in his car. He had to stop the car. It didn't, and the cardiologist did a catheterization and saw a little stenosis, not that substantial actually. So he took the cells, and he was fine in terms of no more chest pain. And he did a re-angio 3 months later, and we could really see that the plaque was reduced. So this is something I would be very interested if we could do that together to really demonstrate in patients that we have an impact on the size of the stenosis. But what we see is a collateralization with little vessels. But this is really optimized, and this is my point, if you first condition with a 3-day or 2-day infusion. Because what we do is when the patients come, we take the blood, put it to the lab to program the cells, but in these 4 days until we get back, give back the cells, we give the infusions to optimize the microenvironment. I'm really convinced that a normal pH will be the prerequisite for optimal cellular activity.
Prof, apart from the anti-aging indication for the infusion, could you share with us, do you have any other experience treating other autoimmune diseases with the same regime? Or
yes, I mean, it starts with diabetes, type 1 and type 2, where you can see that the insulin consumption goes down. The level of AGs, of these end products, go down, which is important because they cause all the problems. So these advanced glycoprotein end products, you can measure them and they go down. We do it in, I treat a lot of neurodegenerative diseases, Parkinson, multiple sclerosis, and Alzheimer. And you will see that you cannot cure the patients, but if you can stop the onset of disease progression, it's already a big thing to do. And this is what I'm convinced of what we do. We treat very effectively rheumatoid arthritis. Any joint inflammation is a very good indication. Vasculitis in terms of lupus, Wegener's disease, all these types of diseases respond very well. And then, of course, metabolic diseases, hyperlipidemia, any metabolic problem. In terms of gastroenterology, it's the Crohn colitis, which responds very good. Steatosis, non-alcoholic fatty liver disease is a good indication.
Then, Prof, how about the cancer patient? You recommend it to do that before their chemotherapy, or?
Well, that's an important question too. Normally, I see the patients when they've had a couple of chemotherapy cycles. So they come because they have problems of the side effects. The earlier you start, the less side effects you will have. So my recommendation is, for instance, if you have a patient who's going to have 3 cycles of chemotherapy, 1 cycle consisting of 6 injections, then I do one infusion before you start and 1 after the 6 injections. And then he has a period of non-treatment and then the next cycle. And then I do the same thing again.
Prof, have you ever treated ankylosing spondylosis?
I didn't hear. How? I couldn't hear it, sorry.
Ankylosing spondylosis. You see the spine
Yeah,
is
yeah,
getting
yes.
injured.
In that case, this is something which also has been, I can give you the publication, related to wrong nutrition and immune activation. It is now considered more or less not to be basically a genetic problem, but to be related to autoimmune processes with